Hi, what I'd like to do today is walk you through some of the major changes that are happening in the DSM-5 and thinking about what it takes to be a good diagnostician. Being a good diagnostician is really one of the keys to being a good therapist. If you don't know what you're treating, it's hard to know how to treat it. Well, the DSM-5 is working towards being more user-friendly. What I'm going to do is go over about 12 slides that really gives you the big picture on the DSM-5. I'm not going to go into the details of the specifics of each of the different diagnoses, but rather try to orient you to the whole way that the book has been restructured. There were certain guiding principles behind the changes to the DSM, at least theoretically. One was that research evidence should support any additions or any substantive modifications. And secondly, there should be as much continuity with the current manual when possible. However, third, they didn't want to put on any a priori restraints about the degree of change between the DSM-5 and the past edition. So if there was no reason to change, they didn't. But if there were reasons to change, they felt free to make as many changes as needed. And then lastly, the last guiding principle was routine clinical practices must be able to implement any of the changes. Otherwise, we'd have a book that wasn't terribly useful. So here are 5 fun facts about the DSM-5. First of all, it's the number 5, not Roman numeral 5, and this was done to allow numbering of revisions. So we could have 5.1, 5.2, etc. Then it was originally targeted to come out in 2009. That got delayed by 2 years to 2011, and now it's set to come out in May of 2013. So this has been about 15 years in the making of the new DSM. The reason it's coming out in May is because the American Psychiatric Association is meeting in San Francisco in May, and so that's going to be the launch of the new DSM-5. There's going to be a 2-year grace period for implementation. However, many agencies are going to want to be making the changes as quickly as possible, particularly when there's third-party payment involved. And lastly, it's going to completely interface with the ICD-11. So some of the code numbers that we're used to are going to change fairly radically. And here's a not-so-fun fact about the DSM-5. The hardback edition costs $199. The paperback is $149, and it's maybe $10 less than that on Amazon. Now, I'm sure a lot of listeners have pet peeves about the DSM. What's important about a new version of the DSM is that each version tries to resolve some of the problems that were in previous versions. So what were the problems in the DSM-4? Well, it actually wasn't very user-friendly. If you looked at the table of contents, for example, it didn't seem to follow any kind of logical order. If you looked in the index was very much truncated compared to the DSM-3. The DSM-3, the easiest way to find anything was to actually go to the index, look for the symptoms you're trying to explain, and then look at all the places in the DSM-3 where those symptoms appear. They greatly curtailed the index in the DSM-4, and it became less useful. Another way that there was a problem in the DSM-4 is that there were 9 different categories for diagnostic uncertainty, and those categories were ordered in terms of the degree of certainty you could have. So, for example, you could have mental disorder NOS, which was the lowest level of certainty or the highest level of uncertainty. You knew there was a problem. You couldn't even say what chapter it belonged in, and all you could say was there was a problem and you couldn't otherwise specify it. Well, those 9 categories were difficult. And in fact, NOS predominated in diagnoses. Another issue in the DSM-4 was that multi-axial review. Sometimes places would require all 5 axes. Not all the axes were terribly reliable. And then there was, throughout the DSM-4, really not enough about culture. There were things about culture-specific diagnoses, but what was missing is things like how depression might be manifest in different cultures. There wasn't enough of that. So DSM-5 is making 5 types of changes. The first type of change is structural changes, the way the whole DSM is organized. The second change is some amount of shifting criteria, adding some new criterion and subtracting some criteria. Third, we're going to see a couple of new diagnoses, some very important ones. Fourth, there's some reclassification of diagnoses so that they appear in different chapters than they did before. And then some diagnoses are going to be gone. So those are the main overall changes. So what are the structural changes to the DSM-5? The first one you'll notice is the order of the chapters has changed. I'm not sure anybody could really say if they knew what the order of the chapters were in the DSM-4. It turns out that they were in order of frequency that people with various disorders show in hospital settings. And this was from data collected by the Centers for Disease Control. So it started with schizophrenia, and then it moved back to children, and then seemed to jump around all over the place. Now the order is going to be according to chronological age. So it's going to start with the disorders that are more common in children, and then towards the end you're going to see disorders more common in the elderly, like dementia. What is another overall structural change? Well, there is no longer the multi-axial system. There are no axes. All of the clinical information goes in one spot. Does that mean they did away with the GAF? Does that mean they did away with the other axes? No. But the information is going to go elsewhere. So now you're going to be asked for each diagnosis the degree to which the person has insight, or how much the disorder is egosyntonic or dystonic. So you will have specifiers for good or fair insight, meaning it's fairly dystonic, poor insight, which might mean some amount of ambivalence or coming and going, syntonicity, and then absent insight, meaning that the disorder is egosyntonic. Are there other structural changes? Yes. You're going to have to do severity indicators. This is what's going to replace the Axis 5 GAF. So some diagnoses will have severity indices that go up to a level 2, and some will go up to a level 3. And some diagnoses are going to require you to have direct knowledge of the patient over a 12-month period, because the severity level is deemed to be severe over, quote, time and circumstances. So what are the severity levels? A 0 meaning none, 1 meaning mild, and probably both a 0 and 1 would correspond roughly to a GAF of 71 or above. A 2 would mean severe, and a 3 would be very severe, probably in the neighborhood of under 31 of the GAF. There are a few diagnoses where you not only need to put severity level for the overall diagnosis, but you need to use severity level for each of the symptoms under the diagnosis. Are there other structural changes? Yes. There is no longer the phrase not otherwise specified or NOS. The phrase is now CNEC, or conditions not elsewhere classified. The CNEC specifier can only be used for 6 months and is only supposed to be used for very specific reasons. There are 5 specific reasons to use CNEC. Because the diagnosis is unclear, so for example, you might have psychotic disorder CNEC. 2, because the clinician is not trained to make the diagnosis. 3, the clinician could not get the information. That might be because records are not available. It might be because the client is uncooperative. 4, you just don't have enough information. You need more time. Or 5, the clinician needs or is required to take more time of direct observation. As I talked about before, sometimes you need to see over time and circumstances that the symptoms remain, and that might be over a 12-month period. Over time and circumstances was put in many places in the DSM-5. The desire was to reduce overdiagnosis, particularly of certain specific disorders. The other major structural changes are that for each disorder, the DSM is going to give you information about the correlation of that disorder to substance use and the correlation of that disorder to suicide. Therefore, if you are treating somebody with a diagnosis that the DSM-5 states has a high correlation to suicide, it would be important to have in your notes that you have in fact done a suicide assessment. Another critical change in the DSM-5 has to do with whether something is caused by a biochemical process, such as bipolar disorder, or is due to environmental factors, and in fact, not just any environmental factors, but what the DSM-5 is calling 5 pathogenic realms. Some of the disorders in the DSM-5 must be due to one or more of the 5 pathogenic realms in order to distinguish them from disorders that are thought to be biochemical. So what are these 5 pathogenic realms? First, persistent disregard of a child's emotional needs. And or 2, persistent disregard of a child's physical needs. And or 3, repeated changes in primary caregivers. And or 4, raised in settings with limited opportunities for stable attachments. And or 5, persistent harsh punishment or other types of grossly inept parenting. And of course, they stop shy of actually giving a definition of persistent harsh punishment or other types of grossly inept parenting. And sometimes these are going to be culturally normative. So they do caution that you keep in mind the norms for the geographic and cultural arena when making these determinations. What are the implications of all of these changes in the DSM-5? Well, hopefully we will see increased reliability. If we can get better diagnoses, then we should see better treatment planning. And it's possible that longer therapy will be authorized because some of the disorders need to be observed over a greater period of time. However, there are some potential downsides to the changes. One is that more work and time has to go into the diagnostic process. The DSM seems to be saying slow down, take your time, make the correct diagnosis in a reliable and valid way, but this is going to take more work because you're going to be determining things like severity level for each of 7 symptoms, for example. It's also possible there's going to be increased demand for outcome studies, that clinicians have to validate their treatments. If the diagnoses are more reliable for, say, something like OCD, obsessive compulsive disorder, it's possible that you might have to show that the treatment you're providing is the one that has been validated in outcome studies. And places like the Department of Corrections are expected to implement that requirement fairly quickly. So the chapters are now in order of chronological age. There are 20 chapters. What you'll notice is that some of the disorders or some of the chapters in the previous book have now been split. So for example, anxiety disorders appeared in one chapter in the DSM-4. We're going to see anxiety disorders in 3 different chapters in the DSM-5. You will see in the table of contents that some chapters have been renamed. So you're probably wondering, if you're looking at the chapter headings, what happened to disorders first seen in infancy, childhood, or adolescence. That has been renamed neurodevelopmental disorders. And then you're going to see some brand new chapters, trauma and stress-related disorders. So the 20 chapters in order: neurodevelopmental disorders, 2, schizophrenia spectrum and other psychotic disorders, 3, bipolar disorders, which is now in its own chapter, separate from chapter 4, depressive disorders, 5, anxiety disorders, but that's only some of the anxiety disorders, because we now have 6 obsessive compulsive and related disorders and 7 trauma and stress related disorders. 8 is dissociative disorders, 9 somatic disorders, 10 feeding and eating disorders, 11 elimination disorders, 12 sleep-wake disorders, 13 sexual dysfunction disorders, 14 gender dysphoria, 15 disruptive impulsive conduct disorders, 16 substance use disorders, 17 neurocognitive disorders, 18 personality disorders, 19 paraphilias, and 20 other conditions. And I believe there's only one thing listed in 20 other conditions. So the most major changes are going to have happened in terms of bipolar disorder, the anxiety disorders now in the 3 chapters, putting feeding and eating disorders separate from with the other neurodevelopmental disorders, major changes in personality disorders, some substantive changes in substance use, new chapter on disruptive, impulsive, and conduct disorders. So this is just previewing some of the more specifics that you would see as you went through each of these diagnostic areas. So I hope what I've done today is give you an overview of the major changes from DSM-4 to DSM-5.